Hi class, welcome to Unit 6 where we're going to talk about the respiratory system. And this is just what I thought was really funny. This is what usually happens when you're talking with your patient and they deny any previous medical history, and then you ask them about their medications. And then it turns out they take a bunch of different medications and have a bunch of different conditions. They just, because they take meds for it, they think that they don't have the condition anymore. So just a little nursing humor there. So let's go into the anatomy of the respiratory system, and this should be pretty much a review from A and P. So you've got your upper respiratory tract, your lower respiratory tract. Upper is your nose, nasal cavity, sinuses, pharynx, larynx, trachea, bronchi. Down in the bottom, the functional units of the lungs, those are the lower respiratory tract components. So the whole purpose behind the respiratory system is bringing oxygen into the body, exchange of gases, and then getting rid of that carbon dioxide. So this is a picture of the respiratory tract, and there are some protective features of the respiratory tract that you should know about. So there are hairs that filter the air. We have cells that produce mucus that help trap material. We have cilia that move that trapped material towards the throat so that we can swallow it. There's also a blood supply close to the surface that warms the air that we breathe in and also adds humidity to it, so that improves gas movement and gas exchange. And then we have our protective cough and sneeze reflexes that work to help clear the airways. So a little bit more about the cough and sneeze reflexes. The walls of the trachea and bronchi are very sensitive to irritation, and when they are stimulated, the central nervous system reflexively coughs, and that cough causes air to be moved out of the bronchial tree with great force, thus clearing the airway of whatever is irritating it. And it's similar with the sneeze receptors. Those are in the nasal cavity, but again, forces those materials right out of the system and hopefully diminish the presence of any irritants. Then we've got the gas exchange. You have to know that gas exchange occurs at the alveolar level. The alveolar sacs hold the gas, and that allows the oxygen to be exchanged with carbon dioxide, okay? And that is where ventilation occurs. Very important. This is just a picture that shows that ventilation. So this ventilation is dependent upon air reaching the lungs. It's dependent on lung volume and capacity. That's the amount of air moved in and out of the lungs. It depends on compliance. That is the lung's ability to expand. And then it also depends on the amount of resistance to airflow. Increased airflow resistance means the person has to work harder to breathe in order to compensate for narrowed airways and decreased gas exchange. An example of that would be a patient that has COPD. Okay, so breathing, the process of respiration, breathing in and out. It's controlled by our central nervous system, and it depends on a balance between the sympathetic and parasympathetic. The parasympathetic nerves stimulate the diaphragm to contract and breathe in. The sympathetic stimulation leads to increased rate and depth and dilation of bronchi. So these things have to be in balance in order for respiration to occur. And then there's also vagal stimulation. There's a vagal nerve, and vagal nerve stimulation leads to bronchoconstriction. Okay, so conditions that can affect the upper respiratory tract. The most common ones are the common cold, which is caused by the rhinovirus. You can have seasonal rhinitis, which is sometimes called seasonal allergies. That's caused by inhaling an antigen or something that the body is allergic to or recognizes as a foreign protein. You can have sinusitis, which can be bacterial or viral. Pharyngitis, laryngitis, which again could be bacteria or viral. Some side notes, the common cold. A cold is most contagious 1 to 4 days before the onset of symptoms and during the first 3 days of the cold. Transmission occurs more frequently from touching contaminated surfaces and then touching your nose or mouth than it does from the viral droplets released by sneezing. But that being said, if you do sneeze, sneeze into your arm, not your hand, and that will reduce transmission of those cold. So that what we're trying to prevent from being transmitted is the rhinovirus. It primarily affects the nasopharyngeal tract versus acute rhinitis. Acute rhinitis can be allergic or non-allergic, and that is inflammation of the nasal mucous membranes, and it typically accompanies the common cold if it's non-allergic. If it's allergic rhinitis, it's by inhaling an antigen. Then there's sinusitis. That's inflammation of the mucous membranes of the sinuses. And then pharyngitis is inflammation of the pharyngeal area, and that is most commonly caused by either a virus or strep. It can happen alone. It can happen along with the common cold or rhinitis or sinusitis. What we usually do for pharyngitis is we would do a throat culture to make sure that it's not strep, because if it is strep, you have to do a 10-day course of antibiotics. Let's see. The groups of drugs used to manage these conditions are antihistamines, decongestants, antitussives, and expectorants. The only time we use an antibiotic is when there is a bacterial infection. If it is viral, antibiotics are not going to help. And usually if they develop a bacterial infection secondary to their cold, they're going to have discharge that becomes thick, mucousy, and yellow or yellow-green in color. Those are the symptoms that it's turned into an infection, and then antibiotics are appropriate. Okay, so then let's talk about lower respiratory tract conditions. We have atelectasis, pneumonia, bronchitis, bronchiectasis, COPD, and we're going to touch base on some of those. First up is atelectasis. Atelectasis is the collapse of lung tissue. So what happens is there's outside pressure against the alveoli, and it commonly occurs with the result of blockage of the airway due to excess secretions. So atelectasis is going to impede the flow, the exchange of oxygen and carbon dioxide. And usually to prevent this, we have people cough and deep breathe. This is a common complication that can happen post-surgically because they're not breathing as deeply as they normally would. They're not up being mobile as much as they would, so they're not breathing as deeply. And so this is why a common nursing intervention post-surgically is for your patient to cough and deep breathe. That forces air into those alveoli and fully expands the lung tissue. From there, we've got pneumonia. Pneumonia is the inflammation of the lungs. It can be bacterial, viral, or aspiration related. You're going to have swelling. The blood vessels are going to become engorged, and there's going to be exudate. So that's like pus in a nutshell. Then we've got bronchitis. Bronchitis is in the bronchi, so narrowed airway. That can be bacterial, viral, or a foreign body affecting the bronchi. And then we've got the obstructive pulmonary diseases, which is asthma, COPD, respiratory distress syndrome, cystic fibrosis. Cystic fibrosis is hereditary, and you will talk about this in peds. Same with respiratory distress syndrome, that is in infants, and you will talk about that in peds. The ones I'm going to focus in on are asthma and COPD. So asthma. Asthma is when the bronchial linings overreact to stimuli, causing episodic smooth muscle spasms that constrict the airway, along with causing mucosal edema and thickened secretions. It's a varying amount of airway obstruction. When activated by a stimuli, for example, an antigen, the bronchial airways become inflamed and swollen, and that leads to constriction of air passages. And in turn, that aggravates airway hyperresponsiveness to stimulate bronchial cells to produce more mucus, which in turn blocks more passageways. What are the stimuli? Well, people can have asthma exacerbations due to stress, allergens, or pollutants. And pollutants can be something like perfume, car exhaust, that sort of thing. Signs and symptoms: coughing, wheezing, chest tightness, difficulty breathing, and many times they will report that their symptoms are worse in the morning or at night. Okay. Then we've got COPD. COPD is a chronic, progressive, irreversible lung damage that causes an increase in airway obstruction and increase in airway resistance. So let's break that down. Chronic means it's long-term. It's never going away. The two main culprits are emphysema and chronic bronchitis. The most likely cause is cigarette smoking. There are some other risk factors that can cause this condition to happen, and that includes recurrent or chronic respiratory infections, allergies, and we've identified a hereditary factor called alpha protease inhibitor deficiency. So that's a test that we can do. So what does COPD look like? Well, it's a combination of two problems. And chronic bronchitis is the obstruction of airflow by mucus and has some common signs and symptoms. These people tend to hyperventilate. They tend to have a productive cough, shortness of breath or dyspnea. They tend to run a little cyanotic. They use their accessory muscles to facilitate their breathing, and they tend to have some pulmonary hypertension. Contrast that with emphysema. Emphysema is a lack of elastic recoil in the lungs due to permanent enlargement of the air sacs and destruction of the alveolar walls. Okay, so this obstruction results from tissue changes, not mucus, like it does in bronchitis-based COPD. It has common signs and symptoms like shortness of breath on exertion. These people can have a barrel-shaped chest from overdistension. They may have a prolonged expiration related to accessory and stomach muscles being used to force the air out, and these people may have decreased breath sounds bilaterally. And just to touch on cystic fibrosis so you're aware of what it is, it's a hereditary disease where a large amount of thick secretions is constantly being produced in the lungs. There's a hereditary component, and the treatment is aimed at fluid, keeping the secretions as liquid as possible so that they can be removed from the airway and keeping that airway open. Okay, so that was a little bit of a review. We're going to move forward to talk about specific drugs that we use for the upper respiratory tract. Okay. So let's talk terminology first and foremost. So there are some specific drug classes that you need to know what they do. The first one is antitussives. Those are like to help with cough suppressants. We've got decongestants. That helps decrease the production of secretions. We've got antihistamines that block histamine. And if it's histamine that is driving the secretions, by blocking that, it will decrease the secretions. Then we've got expectorants. That helps move secretions when you cough out of the airway to clear the airways. And then mucolytics, those liquefy respiratory secretions so that it's easier for them to cough out. So this is just a nice picture of where each of those types of drugs work. And that can help you figure out why we use them to treat certain conditions. So we're going to talk about each class of drugs a little bit more in depth, starting with antitussives. So these are your cough suppressants. They act on the cough control center in the brain to suppress the cough reflexes. There can be non-narcotic, narcotic, or a combination of both. The action is that they work on the cough center in the brain to decrease the cough reflex. We use them when people have a non-productive cough that needs to be controlled. Who shouldn't use these? People who need to cough in order to maintain their airway. We should not use them in people that have had a head injury or have impaired central nervous system function. We want to be cautious using these in people that have a known hypersensitivity or they have a history of narcotic addiction. What are the adverse effects? They can be drying on the mucous membranes. They can cause central nervous system effects, GI upset, and they should not be used with MAOIs. The ones that I want you to be familiar with are listed on this slide. You've got codeine. Codeine is a narcotic antitussive and it will cause sedation. Hydrocodone is available in a combination in some products, and again, it's a narcotic and sedating. Dextromethorphan is available over the counter. It is Robitussin, super common, but we don't want to use it with people that have COPD, and we want to avoid all of these and taking alcohol at the same time, okay? So then we've got topical nasal decongestants. So this means that they work locally on the nasal passageways. So we're applying it directly to the nasal passageways. So we're avoiding a systemic response. So nasal congestion results from dilation of the blood vessels in the nose, and it can be caused by infection, inflammation, or allergy. And with the dilation of those blood vessels, there's a bunch of extra fluid in the tissue spaces, and there's swelling of the nasal cavities. So these topical nasal decongestants, they produce constriction of the capillaries, and that reduces fluid secretion. Frequent use of decongestants, specifically nasal sprays or drops, can result in tolerance and rebound nasal congestion. Rebound nasal congestion is caused by irritation of the nasal mucosa. It is corrected by stopping the nasal decongestant. Most of these nasal decongestants should only be used for up to 3 days. Going beyond 3 days could result in rebound nasal congestions. So stopping it will fix the rebound nasal congestion, okay? So your Afrin, your corticosteroid, if they are nasal sprays that are decongestants, they're only supposed to be used for up to 3 days, okay? Let's talk a little bit about their action. They are sympathomimetics. So they affect the sympathetic nervous system to promote less inflammation of the nasal membrane. When do we use them? We use them to relieve discomfort of nasal congestion. It could be due to the common cold, sinusitis, or allergic rhinitis. They're not usually absorbed systemically. They shouldn't be used if your patient has a nasal wound. If the tissue is not intact in the nasal cavity, nasal membranes, they shouldn't use these. And usually they're well tolerated, maybe some localized stinging and burning, or rebound congestion if they overuse it. So what are some assessment considerations? Do they have, what's their history, what's their physical, do they have any allergies? Of course. We're going to assess for their nasal mucous membranes, urinary status. These are great choices to use for people that have systemic diseases because topical nasal decongestants don't cause a systemic response typically. Okay, so if you have a patient that has high blood pressure, we usually don't want them to take an oral nasal decongestant because that could raise their blood pressure. But if they use a nasal spray, that reduces the risk of that blood pressure going up. And then oral decongestants is our next topic. So the most common one is pseudoephedrine, very common over the counter. These will cause an elevated blood pressure, elevated pulse. So if your patient already has tachycardia or hypertension, you want to be very cautious. These ones should be limited to using for 1 week. Okay? Anything beyond that, you've got to check in with your doctor for it. And you want to be careful drinking caffeine when taking an oral decongestant because caffeine will increase restlessness and the risk for heart palpitations. What do these do? They shrink the nasal mucous membrane and decrease the nasal congestion. That helps promote drainage of the sinuses and improving airflow. Adverse effects, again, you could have rebound congestion. You could have systemic effects. You don't want to double dip. So you don't want a patient taking 2 medications that both contain pseudoephedrine. So don't take Sudafed and triamcinolone. Don't take Sudafed and any other over-the-counter medication that contains that as a main ingredient because that can cause serious side effects. What do we need to know before giving an oral decongestant? History, physical, any known allergy, and we should avoid them if the person is pregnant, breastfeeding, hypertensive, coronary artery disease, hyperthyroidism, diabetes mellitus, enlarged prostate, and then we want to do a good assessment. Okay, so we've talked nasal decongestants and oral decongestants. Next, we're going to talk about topical nasal steroid decongestants. Okay? So these are most effective for treating allergic rhinitis. They have an anti-inflammatory action, which decreases allergic rhinitis symptoms like rhinorrhea, sneezing, and congestion. With continued use, they can cause dryness of the nasal mucosa. And we have to educate our patients that it takes about 2 weeks for the full effect, and they should point the nasal spray back and not towards the nasal septum. Some examples that are very common, these are all available over the counter at this point in time. Rhinocort, Flonase, Nasacort. Contraindications, we might not want to use these if they have an active infection. You'd want to double check with the doc. What are the adverse effects? Usually they're well tolerated. You can have some localized burning, irritation, dryness, or headache. It can slow the healing process if your patient has had nasal surgery or nasal trauma. Okay, so these are different than topical nasal decongestants because these are steroids. Okay, very important distinction. So let's go ahead and talk about antihistamines next. Antihistamines compete or block histamine, which is a part of our immune system that triggers inflammation. When histamine is activated, smooth muscles, including those that line the nasal cavity, are constricted. And so these will treat that problem. Antihistamines can be divided into two groups, first generation and second generation. Most first generation antihistamine cause anticholinergic symptoms. Dry mouth, drowsiness, urinary retention is a possibility. We're going to talk about those more on the next slide. A lot of over-the-counter cold remedies contain a first-generation antihistamine. So we also want to advise these patients not to drive or operate dangerous machinery when taking these meds. So who could take these? People that have seasonal or year-round allergic rhinitis. Those are the most common ones. So if you have allergies that affect you all spring, all summer, or all year round, you're going to take these. And these are all available over the counter. Who should we be cautious in using these on? People that are pregnant or breastfeeding, people that have impaired renal or hepatic impairment. These can cause some liver function changes long term. So if people are on these for years, we should check periodic liver function tests. Just a little bit of background difference between first generation and second generation. Diphenhydramine is Benadryl. And Benadryl is a great first generation antihistamine, but it does have some limitations. It only causes an effect for about 6 to 8 hours. So if you have 24-hour symptoms, you've got to take it upwards to 4 times a day. It is more sedating than second generation antihistamines. So what that means is if you're having trouble sleeping at night because of your allergies, Benadryl is a great resource. But if you want 24-hour control of your allergy symptoms, you should turn to a second generation antihistamine like Zyrtec, Allegra, or Claritin. These ones are usually once daily dosing and less general sedation. Okay, so all of them have the risk of causing anticholinergic side effects. First generation, like Benadryl, is more likely to cause anticholinergic. Second generation are less likely. And these are those key signs and symptoms. So anytime you hear anticholinergic side effect, these are the things you should be thinking. They could be hot as a hair, dry as a bone, blind as a bat, red as a beet, and mad as a hatter. These are adverse effects. We are going to be watching for these. Okay? They can progress to a crisis, which is on the far right-hand side. Okay? So nausea, vomiting, bradycardia, tachycardia, lethargy, diarrhea, urinary retention, all those sort of things. So these are side effects and adverse effects that we need to be monitoring these patients for and tell them to report to us if they have these problems. Okay, so nursing considerations for antihistamines. We want to assess for urinary retention. So if your patient hasn't urinated in 8 hours, we're going to assess for bladder distension. That is a symptom of urinary retention. If it's a first generation antihistamine like Benadryl, we're going to tell these people to take it at bedtime, and the people will sleep better as well. And just as a side note, a lot of the over-the-counter sleep aids contain Benadryl as the active sleep ingredient. There is a possibility of a paradoxical effect with Benadryl, where instead of sedation, people become agitated, and a paradoxical effect is a little bit more common to happen in children versus adults. Who shouldn't take these antihistamines? Well, we want to be cautious and double check if they've got liver disease, narrow angle glaucoma, or a history of urinary retention, because it can make these problems worse. What do we want to do nursing intervention-wise? We want to get a list of environmental exposures, drugs, recent foods, stressors. We can educate people that if they do have gastrointestinal distress, they can take these with food, and that will decrease that. We want them to avoid alcohol and other central nervous system depressants. We want to avoid in acute asthma attacks because it's not helpful. It's not first-line treatment at all. And then we can advise them to use sugarless gum or ice to suck on if they have dry mouth with these medications. So a lot of weird, odd things that you need to know and be able to apply with the antihistamines. So then we switch over to expectorants. Expectorants loosen or thins bronchial secretions so that they can be expelled by coughing. And hydration is the best natural expectorant. So when taking an expectorant, we should encourage the patient to increase their fluid intake to at least 8 8-ounce glasses of water per day to help loosen the mucus, unless contraindicated due to another condition. So what do expectorants do? They reduce the stickiness and the surface tension of secretions so that it's easier for it to get out of the airways. Who should take these? People that need relief of a non-productive dry cough, because just coughing too much can irritate the airways more and make the patient feel worse, and it could be difficult to talk or work. So these will help with that. Mucinex is probably the most common one that you'll hear. Guanafensin, which I have a terrible time saying, I apologize, is a common ingredient in a lot of over-the-counter cold medicines too. Let's see. Adverse effects. They can have GI symptoms, headache, dizziness, mild rash. We don't want them to take this for a long-term solution because it could be masking a more serious problem. Our nursing considerations, do they have any underlying problems like smoking, asthma, emphysema? Those could be reasons why they should not be taking it, because we need to treat those underlying problems first. Then we've got our mucolytics. Mucolytics liquefy. So they work to break down mucus in high-risk respiratory patients and help them cough up what was previously a thick secretion. So who do we use these for? We use these for people that have difficulty coughing up secretions. So that could be an elderly patient because they have a decreased cough reflex. It could be people that are post-operative, people that have a trach. Acetylcysteine is a mucolytic. It can be taken inhaled as a mucolytic. It can also be taken orally. It is the antidote for Tylenol overdose. That is really important to remember. Little bit more about mucolytics. Okay. They act like detergents to liquefy and loosen thick mucus secretions so they can be expelled. Acetylcysteine is the one I want you to remember. That is commonly given by inhaling it through through a nebulizer. It shouldn't be mixed with other drugs. If you do have to give it with a bronchodilator, you can't mix them. You should give the bronchodilator first, then the mucolytics. Let's see. The other drug that was on the slide, Pulmonise. I think I said that wrong. Pulmonise. Anyway, Dornase alpha is the generic, and that is primarily used for people with cystic fibrosis. So what are our nursing considerations? Do they have any bronchospasms, peptic ulcer, esophageal varices? Those are risk factors that we may want to question the usefulness and appropriateness for a mucolytic in that patient population. Okay, so that brings us to drugs that affect the lower respiratory tract. So first I wanted to just revisit the changes that occur to the airway with COPD. We've got on the left normal alveoli sacs and then emphysemic alveoli sacs. You can see they're much larger, and that's where the air gets trapped and isn't able to diffuse effectively. Then on the right side of the screen, you've got a normal bronchi versus chronic bronchitis. The inflammation, the mucus, you can see that. You can see those. So what happens is with both of these conditions, the lungs are damaged in a way that airflow is limited in and out of the lungs. So that's why we have the manifestations we have. So air is trapped, the alveoli don't work well, and exchange of gas is greatly impaired. We need to first talk prevention and treatment of COPD. So we want to reduce environmental exposure to irritants. We want to advise to stop smoking. We want to get all possible allergens out of the air. So sometimes these people need HEPA filters running in their home. We want to avoid exposure to known irritants and allergens. We want to help open up those airways and decrease inflammation. There's different delivery methods for these medications. You can use an inhaler or a nebulizer, or you could take a pill. Inhalers require some coordination. Inhalers, if we're going to deliver a med through inhalation, you have to depress the canister, hold the breath for as long as possible or to a count of 10, versus a nebulizer is an aerosol medication delivery system. They take about 10 minutes to complete, and for the best benefits, your patient has to sit upright through the duration of the treatment. And nebulizers take the medication and have it reach deeper into the lungs versus an inhaler. There is adult respiratory distress syndrome, and these are the key characteristics, causes, and treatment. I'm not going to spend much time on that because you'll get that in greater detail in term 6 with Professor Bochart. Now we're going to talk about some drug classes. The first one I want to talk about are xanthines. They work directly on smooth muscles of the respiratory tract, both the bronchi and the blood vessels. It dilates the airways. It provides symptomatic relief and or prevention of bronchial asthma and treating bronchospasm associated with COPD. The downside with xanthines are they have a narrow therapeutic index, and so they're not first-line choices for treatment, okay? Theophylline is probably the most common one, and has a narrow therapeutic range. So if their serum level is 10 to 20, they're fine. Toxicity occurs anything over 20. So you have to monitor lab levels, and you have to monitor for signs and symptoms of adverse effects. And we're going to talk about that on the next slide. You also have to tell these patients to avoid caffeine, increase their fluid intake, and if they smoke, they're going to need a higher dose. So who shouldn't take azanthine like theophylline? People that have GI problems, coronary artery disease, respiratory dysfunction, they have renal or liver problems, if they're alcoholic or hyperthyroidism. The adverse effects we need to watch for is GI upset, nausea, irritability, tachycardia, and it can go even further to seizures, brain damage, or death. So this is why these are not first-line medications. We don't start a newly diagnosed COPD patient or a newly diagnosed asthma patient with theophylline, because it also has a lot of drug interactions as well. So this is kind of third choice. You know, if we can't get good control with our first line, second line, we may consider adding one of these, okay? But it's still important to be familiar with these. And so this is the nursing considerations, which I've already touched on a lot of them, but be sure to read these. Now, another drug class are the sympathomimetics. They mimic the central nervous system, and that will cause dilation of the bronchi because it relaxes smooth muscles and decreases inflammation in the airways. These are also called bronchodilators. We can use these to treat asthma or COPD. Most common ones here is your albuterol and your epinephrine. Albuterol is a rescue medication. It's first line for an acute exacerbation of asthma or COPD. It's typically an inhaler that the patient carries with them. We can deliver it through a nebulizer. So if we deliver it through a nebulizer, remember it takes longer, but it reaches deeper into the lungs, so it's going to be more effective for an acute exacerbation. If albuterol is ineffective, then we would turn to epinephrine for a prolonged attack that isn't responding to normal treatment. So albuterol is a short-acting bronchodilator and the drug of choice for acute attacks of bronchoconstriction. Okay? Let's see. Moving forward with the sympathomimetics, beta-2 blockers. We talked about beta blockers in terms of the heart. Now we're talking about it for controlling bronchospasms, bronchoconstrictions. So beta-2, remember that refers to the lungs. Beta-1 is the heart, beta-2 is the lungs. We can give these, like epinephrine is an injection. We can also inhale sympathomimetics, beta-2 agonists, beta-2 blockers, however you want to refer to them. They can be given by aerosol, they can be given by nebulizer, they can be by injection. Okay, let's see. All right, so let's talk the benefits of an inhalant. Inhaled beta blockers work faster, smaller doses are required, and there's a lower risk of side effects versus an injection is going to have more side effects because it's going systemically. Okay, what are the adverse effects? The adverse effects are it's going to activate the sympathetic nervous system. So GI upset, heart arrhythmia, hypertension, it could paradoxically cause bronchospasm, sweating, paleness, flushing. Usually when you give an albuterol nebulizer, your patient is going to have tachycardia because of that activation of the nervous system. They may have a tremor. They may be shaky, that sort of thing. What are some nursing considerations that are listed on this slide as well? And then that brings us to our anticholinergics. So remember that slide back in the beginning. Anticholinergic side effects: hot as a hair, dry as a bone, blind as a bat, red as a beet, mad as a hatter. Okay? Let me get back to where I was. Anticholinergics. These are used for people that can't tolerate a sympathomimetic. So ipratropium, tiotropium, those are common ones. Atrovent is more for asthma. Spiriva is more for COPD. These are also good at long-term maintenance, preventing acute exacerbations. These are not treatment for an acute exacerbation, but they can help prevent and minimize exacerbations. Okay? Let's see. Tiotropium is used for maintenance treatment of bronchospasms related to COPD. It is an inhaled medication, as is ipratropium. That is also an inhaled medication. Okay? So anticholinergics help treat bronchospasms. They have a fast onset of action when inhaled. Who should we be cautious with? People that have urinary retention, narrow angle glaucoma. I would say the same that we talked about earlier in this presentation. Adverse effects: dizziness, headache, sleepiness, sore throat, urinary retention. What assessment do we need to do? Pulse, blood pressure, respiratory, of course H&P, that sort of thing. And then we switch over to inhaled steroids. Inhaled steroids are very effective for treating bronchospasms, but they take time to work. They are not used for acute exacerbations, okay? So let's talk about these. So they decrease the inflammatory response in the airway. They're helpful for preventing and treating asthma. They take 1 to 4 weeks for an inhaled steroid to reach its full effect. So if you are dealing with an acute exacerbation, you're going to give them a pill or an IV because those are going to start working much faster than an inhaled steroid. Okay? So steroid, another way to say that is a glucocorticoid, if you remember that. Glucocorticoids, because it's inhaled, doesn't usually cause systemic problems like elevated blood glucose, irritated stomach lining, because it's localized, it's being inhaled, it's working directly on the lungs themselves. We don't use inhaled steroids for acute attacks. The common adverse effects are listed on this slide. What do we need to consider? Let's see. With inhaled steroids, the education you need to provide is they have to rinse their mouth out after each use, because otherwise they can develop a yeast infection, Candida albicans, which manifests as white spots on their oral mucosa or like a sore tongue. And so by rinsing the mouth and throat with water after each use, we decrease the risk of that happening. Okay? All right, and an example of an inhaled steroid is not listed on here, but I want you to think about is Advair. Advair is, spell check really doesn't want me to say Advair, is a combination of a glucocorticoid and a beta-2 agonist. So it's very helpful. It's used to treat both asthma and COPD, but it takes weeks for full effect. And it's not used for an acute exacerbation. Okay? All right. So we talked about that, touched on that. We are nearing the end. The next class I want to talk about are your leukotriene receptor antagonists. That most common one is singular. These again are not for acute symptoms. Okay, leukotriene is a chemical mediator that can cause inflammatory changes. So these block those. These are very helpful for treating asthma. It is a preventative medication though. It is not used for acute symptoms. Okay, for chronic asthma, it's usually taken at bedtime, and we need to monitor liver function tests with this medication. Okay, let's talk a little bit more. Its indication is for bronchial asthma. I think they're trying it with COPD, but I don't know if there's been clinical tests that really, or clinical trials that show that it's super helpful. But sometimes if they're having difficulty controlling COPD, they'll try a leukotriene receptor antagonist like singular as well. Caution with hepatic or renal disease, pregnancy, lactation, adverse effects, headache, dizziness, myalgia, nausea, diarrhea, elevated livers, drug-to-drug interactions. They do interact with just a few things. Nursing considerations, don't use it for an acute bronchospasm or asthma attack. Be cautious if they have any renal or liver impairments, and do a good assessment. And then the last drug is kind of a unique drug. It's for asthma. It's not used very often anymore. It acts by inhibiting the release of histamine to prevent an asthmatic reaction. Its most common side effect is a bad taste that can be decreased by drinking water before and after, and a cough. But again, just be familiar with this drug and the key things that are on this slide, but it's not super commonly prescribed anymore. Okay, that brings us to the end. This is a really complicated unit, so please let me know if you have any questions about which are front line, second line, what are the key things for each of these drug classes. Just let me know if I can help you. Thank you so much for listening, and have a great day.